Greetings and welcome to another lecture in psychopathology. This particular lecture and this particular section deals with psychological treatment. Starting out with generalities, why do people seek treatment? And it's not quite as obvious as, it would seem. One reason, of course, is that they may have or think that they have a psychological disorder. This is not rare. Psychological disorders. I pointed it out a couple of different times over the course of this semester. It is not rare. And in fact, it suggested that roughly 15% of adults in the USA receive mental health care every year. Now, not everybody is getting this from a psychologist or a psychiatrist. You could be getting it from your general practitioner. It could be therapy. It could be medication. There are all sorts of things that could be involved in this. But yeah, 15% is not exactly rare or unusual. Some people seek psychological treatment because they're having stressful life circumstances. Now, this isn't a disorder, okay? This isn't that they have a particular disorder and they need to be diagnosed and such. It's simply that their life feels so off balance and they're so stressed out by it that they feel overwhelmed and they just want to figure out if someone might have answers as to how they could make it better. Other people seek psychological treatment because they have no choice. And having no choice can be any of a number of factors. It could be that they've been court-ordered to undergo some kind of therapy. It could be that they are a dependent minor and their parent forces them to. It could be that their spouse is saying, get treatment or I'm out of here. It could be that the problem is too much for a physician to help for an MD, so they need to go to a psychiatrist or to a psychologist to help. Could be any of a number of things. I will point out that when it comes to voluntarily seeking help, that fewer males than females do so. So males are possibly a bit more likely to be voluntold, as they used to tell me about when I worked for the Marines. They're voluntold that they need to do this. And some people seek out therapy simply because they want to become the best person that they can be. They think that they haven't lived up to their full potential. They haven't lived up to everything that they could be. And so therefore, they decide to go seek therapy in the hopes that they would therefore improve. Now, who provides these therapeutic services? There are a couple of there are a lot of different. There's more than a couple. The first are what are called clinical psychologists. Clinical psychologists have a PhD in psychology, preferably clinical psychology. I have a PhD in psychology, but I'm not a clinical psychologist. So they have a PhD in clinical psychology, which usually involves a lot of information about different types of treatments and testing and that sort of thing. A PhD involves, on average, or ideally 4 years of study past the bachelor's degree, and it usually involves an internship of some kind. So it's somewhat analogous to the psychiatrist. A psychiatrist has a MD, is a medical doctor, but instead of specializing in oncology or gerontology or some other ology, they specialize in psychology. And for the most part, by the way, psychiatrists are the only people, they're the first person, at least on this list, that can prescribe medication. For the most part in the United States, only medical doctors are allowed to prescribe medications. Psychologists can suggest and recommend and send the person to a psychiatrist who may well then go, yes, that sounds good, and write the prescription. But with very few exceptions, psychologists cannot write prescriptions for anything because they are not medical doctors. Psychiatric social workers can also provide psychotherapeutic services. They very often have a master's degree in social work. So this is 2 years roughly after the bachelor's degree. An MD, by the way, is at least 4 years of medical school plus 2 or 3 years of internship and so forth and so on. It takes a while. Non-psychiatrist physicians also can provide psychotherapeutic services. In fact, a lot of people, including myself, I received my prescription for psychotherapeutic medication from my general practitioner. Doctors have the ability to prescribe pretty much any medication because they're doctors. And so, yes, you can indeed have psychologically relevant medication prescribed to you by a general practitioner. It's just that since that person is not an expert in psychology, basically, in psychiatry, it can sometimes be better off to go see a psychiatrist. simply because they're going to have the most up-to-date information and the most expertise. However, for relatively minor things, then sure, your general practitioner can probably help you. Clergy can also help. Priests and reverends and preachers and whatnot, they do a lot of counseling. It's not necessarily going to be medical related in this case, but it certainly can have to do with things like stress. And since stress seems to be the root cause of a whole lot of disorders, that would certainly be a useful thing to have. Whenever someone is going into therapy, we start to talk about the therapeutic relationship. What should be going on whenever someone is seeking psychotherapy, whether it's from a psychologist or a psychiatrist or a clergy or whoever? What should be part of this? The things that tend to work best include a sense of working collaboratively. There are some branches of psychotherapy where basically the therapist is in charge, and when he says jump, the patient says how high. But that isn't always how these things work. And it works a lot better when the patient, or in fact the client, a lot of psychologists and psychiatrists use client, because patient just sounds so me doctor, you patient kind of thing. And client is more of an equal, and that indeed can help this relationship. It also helps if both parties agree on what the goals are. And this might sound kind of ridiculous, but the psychologist may want to try to fix everything, and the client may be like, oh no, you just fix this little bit and I'll be fine, or vice versa. So it helps if everybody agree what the end goals is. A lot of times, the end goal is going to be some variation of this, that the person is going to give up their old dysfunctional behavior patterns and replace them with new functional ones. Now, this could be done through talk therapy. This could be done through, through pretty much any of the types of therapy that we're going to be talking about for the rest of the chapter. It could be done through medication. It could be done through chatting it up with your clergy member. It could be done with chatting with a best friend. So, yeah, I mean, anything that would try to replace what isn't working with what is would count. It also helps if there is an emotional bond of some kind. Remember, affect is a fancy word for emotion. And if there is indeed an emotional bond of some kind, it usually means that they like each other, they trust each other. You don't want to get too far into this. The cliche of a therapist sleeping with his or her, usually her, clients, is indeed that, a cliche. It's also highly illegal. But it does help if you like the person and they like you. In fact, there are some types of therapy, like the humanistic therapy, but that's pretty much a requirement. That if you don't have that, then you're simply not going to get anywhere. If we're going to be talking about how to give psychotherapy, we're also going to talk a little bit about how to measure whether or not it's successful. And some of this sounds kind of, well, of course you'll know it's successful. How? I mean, sometimes change is not clear-cut. Sometimes change is not as immense or as intense as you want it to be, and yet there may still be success. So there's all sorts of possibilities for trying to objectify and quantify change. One is by asking clients to rate their therapist, which isn't always reliable because, after all, it's not entirely on the therapist to get the job done. The client does indeed have to do some things on their own. Also, if the client winds up with a result they don't like, it's a possibility that they're going to give a bad review. Or if the client doesn't understand, or if the client, or the client thinks everything's wonderful when the therapist did nothing. There's lots of problems here. So how about asking the clinician? That's just as bad in the opposite direction. In that the clinician may think, well, I did a wonderful job, but they sucked. Or, or the client didn't held up their end of the bargain. Or, I think that I do wonderfully, especially compared to the quack down the street. Or they say they do well because they don't want to feel bad that they're wasting people's time and taking their money. Or they say they did well because they're lying. Or, there's all sorts of reasons why that might not be reliable either. So there are other things to try. You can ask for a third party to come in and judge. Usually, in psychological studies anyway, this consists of people who are trained to rate change. Blind to condition means they don't know, for instance, what therapy the person got. They don't know if they got a real therapy, if they got a placebo therapy. All they do is go in and check and see if there has been a difference. Is there a difference or not? Because, of course, if the person knows whether or not they've been treated or what they've been treated with, that could alter their responses. That's why you want to go with third party. And quite frankly, this works quite well. It really does work. As long as you have people trained who go in not knowing if the person they're talking to has had the treatment or not had the treatment, or for how long, or what kind of treatment, or nothing, but just to find out whether, how they score on a test, or whether they've improved, or whatever else. It does seem to work quite well. There are other measures that can be done. There are some objective measures, for instance. Now, objective measures are just that. They're not subjective. They're not asking people's opinions. They're actually going in and doing, say, an objective type of test, so that they're trying to get that information without letting people's opinions or judgments or desires or anything get in the way. So we can do scores on psychological tests, which indeed can turn out to be useful. We'll give them a test before, we'll give them a test after. The problem here, of course, is something called regression to the mean. And if you've taken statistics, you know what that is. Regression to the mean suggests that people who score either extremely high or extremely low on a pretest very often will wind up scoring a lot closer to average on the post-test, even without any treatment. Things happen to cause the person to score extremely high or extremely low. And those same things may not be present the second time. Maybe they didn't get enough sleep. Maybe they were hungry. Maybe they didn't understand the test. Maybe taking the test the second time made them do better. Maybe taking the test the second time made them do worse. So you need to get around that if you're using a pre-test, post-test, simply because it's possible that something else is causing the change that isn't the treatment. So sometimes physicians will do things like measure brain activity in something like a functional MRI or a PET scan. And indeed, that would be very difficult to fake. That would be objective. People can't really lie. It's not up to someone's opinion. You've got numbers, you've got data, you've got pictures. And so that often can be more objective to try to test something. Of course, last but not least, we can simply look at people and give an informed judgment. This is not the same as the third party. Third party go in and interview and, dig down deep. Overt behaviors is simply going and watching people and saying, they look better. I think they look better. Or, no, they don't look better. Change is not always observable. Certainly not over in a short period of observation, or an observation in only one particular environment or at one particular time. So yeah, not particularly useful. However, whenever we're looking to see whether or not therapy works, we need to take into account something called spontaneous remission. And that is the fact that for many people with many disorders, these disorders may well simply go away all on their own. That even without treatment, people may have improved simply by time passing. This tends to be true in things like the anxiety disorders and the mood disorders. And for that, it's classic. That a person is in a situation that causes a lot of anxiety, the situation ends, the anxiety goes away. The person who's doing the treatment says, what I did was wonderful, when in fact it wasn't. It was the environment, or it was time passing, or people are depressed in the winter and summer comes and all of a sudden they're not depressed anymore. It has nothing to do with the treatment. So whenever any sort of rankings or ratings is being done to measure success in psychotherapy, you always need to take into account the fact that, as I mentioned before, sometimes people get better and disorders go away all by themselves. Which does not, by the way, mean that you shouldn't seek treatment. You should, but still, they can and do go away sometimes.